mindful of everybody's time, and I have set it to mute as people come in. Good afternoon. My name is Victoria, and I'm the Education Coordinator here with Michigan Center for Rural Health, and will be facilitating today's program. I would like to welcome everybody to today's Legal Grand Round entitled SGR, the MIPS program for provider population. It is provided by the Michigan Center for Rural Health and Hall, Brender, Killian, Heath, and Lyman. Before we begin, just a couple reminders. If you are logged into the webinar portion, you can have you can use the computer speakers and the computer microphone. You can also listen to the audio via the audio number provided, and our handouts were emailed and are also posted on our website now. Our website is mcrh.msu.edu. Click on the education link on your left, scroll down, click on the Legal Grand Round, find today's date, and there you will see the presentation and an evaluation. If you would like to ask a question during the program, please type the question into me in using the chat feature, and then I will read it to the presenter during the Q&A during the Q&A at the end of the program, or you can wait till the Q&A at the end of the program and I will unmute all the lines. I am pleased to introduce our speaker today, Brian Bauer, who is an attorney and shareholder at Hall, Brender, and with that, I will turn it over to Brian Bauer.
Well, thank you, Victoria, and hello, everyone. Good to have this opportunity to meet with everybody, even if it is just over the phone. Background of this webinar is that it kind of grew out of the health law update I did for the Michigan Center for Rural Health at their annual conference back in May of this year. One of the topics that we covered in the health law update was the merit-based incentive payment program that was part of the new legislation passed in April. And so the center asked me to do a webinar basically to expand the audience or to reach others that were not able to be at the annual meeting in May. So that's kind of the background. I think in addition to that introduction background or procedural background, we probably need to take a look at some historical background as well. You may not realize it, but in March of this year, there was a birthday, or probably more correctly, an anniversary. In March of this year, the Affordable Care Act turned 5 years old. Kind of hard to believe that we've been operating with the Affordable Care Act for 5 years, but it's been there. I think in some regards, it may seem like it's not really gotten much traction. We had some legal challenges, couple Supreme Court decisions on its legality, and of course, there's been a lot of talk from one party or the other about its repeal. I think we're finally past all of that now. I know we're heading into another presidential election cycle, so we may hear some of it come up again. But realistically, I think the Affordable Care Act is here to stay. And even though sometimes it may not have felt that way, CMS has been actively pushing and moving in the direction of the Affordable Care Act. The Affordable Care Act, among other things, really contemplated the creation of 12 or 13 new payment or healthcare delivery models. Out of that 12 or 13, only one was actually a new program. The other ones were pilot programs or demonstration projects. There was only one that was meant right from the beginning to be a new program, and that is the Medicare Shared Savings Program. And the way you participate in the Medicare Shared Savings Program, if you're a provider, is through an accountable care organization or an ACO. And realistically, I mean, if you look at Medicare's news releases, they will seem very happy about the number of ACOs that have been added since they could first apply in 2012. Realistically, there has been growth, but probably not as much as CMS would have hoped. I think some of that's going to change this year. There was, through the CMS Innovation Center, a grant program that actually allows funding for those hospitals, and in particular small and rural hospitals that wanted to participate in the program. It actually, I tend to think of it as a scholarship program. The Innovation Center was providing grant funding to allow small and rurals to use that money to participate in the Medicare Shared Savings Program. And so I think we're going to see a large expansion. I know that the number of small and rural hospitals in Michigan that were particularly participating in the Medicare Shared Savings Program went from one hospital and one rural FQHC to 16 hospitals and one rural FQHC in Michigan. So there's been a lot of growth, and I think there's going to be continued development in that area. And the reason that I'm kind of spending some time giving this background is, realistically, CMS treats the Medicare Shared Savings Program and the accountable care organizations as their research and development arm. That is really how they are developing their policies, their procedures, and their approach to population health, to value and quality over volume. And so I think it's important to pay attention to what's happening in the Medicare Shared Savings Program, even if your hospital is not particularly or specifically participating in the MSSP, just because that is really where CMS is doing their R&D type development. And actually, as we go through this language with regards to the MIPS program, we're going to see some of that research and development, some of the things CMS has learned in the Medicare Shared Savings Program in the new legislation. So that's kind of the reason for that background. And then the other point of kind of historical background is the fact of why do we actually have this new legislation? As you see on the screen, in April, President Obama signed the Medicare Access and CHIP Reauthorization Act, or MACRA. Now, MACRA, in one sense, has been in the making for a number of years, because what it really is intended to do, or was its primary focus, was to fix the SGR problem. The SGR problem, or the sustainable growth rate problem, had been a part of the legislation and the legislative and regulatory background for healthcare reimbursement for the physician side for a number of years. And basically, the sustainable growth rate concept was, it was tied to the economy of the country. So if the economy grew, then the growth rate grew, and the adjustments that physicians received on their payment schedules, their fee schedules, also grew. Well, the problem with that was that when we hit a recession, it actually went negative. And that's the problem, the SGR problem, that we've had for a number of years, is that if the SGR, the sustainable growth rate, was actually implemented and as it is designed in this, or as it was designed in the legislation, you would have had physicians taking something between a 20 and 25% reduction in the amount they were paid to provide services. Clearly, that wasn't going to work. And so every year, every 6 months, we had this temporary SGR fix going on. And the Medicare Access and CHIP Reauthorization Act, MACRA, was meant to be the permanent fix to the SGR rate. So no more kicking the can down the road. And so that's really what the background behind that legislation is. Now, getting into MACRA a little bit, the SGR legislation fix, First thing is it forever fixes by doing away with the sustainable growth rate. That whole SGR compensation or adjustment to physician compensation is now gone. Now, a couple things the SGR legislation or MACRA did not fix is the 2 midnight rule. I included this because actually there was some hope that the legislation was going to include a fix. So the 2 midnight rule, which has been delayed and delayed and delayed, was not fixed. It's still out there, and actually effective October 1 of this year, enforcement will be permitted. I mean, it was delayed in the sense that no enforcement was allowed. That enforcement will be allowed to begin or through the audits starting October 1 of this year. The MACRA also did not fix the 96-hour rule. So for critical access hospitals and the whole issue about the condition of payment and having to have that certification by the physician at the time of inpatient admission that the patient expected to be transferred or discharged within 96 hours, still in effect. So unfortunately, MACRA did not fix that. So what did MACRA do? If they didn't do the other things, what did MACRA actually do? Well, I said it got rid of the SGR legislation and issue, and it established the new payment updates. So the increases that physicians will see on their compensation for Part B services. So there was no update for the first half of the year. Starting in July 1 of this year, there's a update of 0.5%, and that's the update that physicians are going to see from now through 2019. One thing of note, larger payment updates for payments through an alternative payment model. So if your physicians are participating in an ACO that participates in the Medicare Shared Savings Program or other alternative payment model, there is going to be a larger update. CMS wants to move the whole system to an alternative payment model. Now, that may be a little bit of a broad statement, but realistically, CMS is very committed from getting away from the current volume-driven model to a value-driven model. The largest existing alternative payment model currently is the Medicare Shared Savings Program, but we did see some new rules come out just a month or two ago with regards to bundled payments and episodes of care. So CMS is expanding the world of alternative payment models, but it's clear through regulation and in reimbursement incentives, they want to move the industry to the direction of value versus volume. And so this is one of those carrots or incentives here. There's going to be actually larger updates for physicians who receive payments through an alternative payment model. All right, so one of the things, the thing that we're really focusing on today is the MIPS program, or Merit-Based Incentive Payment System. Now, this may just show how much of a geek or a nerd I am with regards, and maybe I just spend too much time in CMS regulations and rules. But one of the things that I find interesting is CMS is now defining their own acronyms. It used to be acronyms just were a combination of putting together the first letters, and there you had your acronym. Here, this really should have been MBIPS, but they've defined their own acronym. Again, silly aside maybe, but it's amusing to me. So the Merit-Based Incentive Payment System is going to be the new process by which CMS is going to update and adjust physician payments. And it actually sunsets, MIPS doesn't, but it it replaces a couple of existing programs which will sunset in 2018. Specifically, meaningful use will go away as a separate adjustment or payment. So will PQRS and existing value-based payments. Instead, these are going to be rolled into the new MIPS payment program.
Brian, sorry
Yeah.
to interrupt you, but the slides aren't advancing.
Oh, okay. I'm not sure how to. Go ahead.
Hold on a second. Let me make sure that you're the host here. Try now doing your slides again. Can you try resharing your screen?
All right.
I don't know why it's not advancing. It seems to just stuck on that one.
Which one was it stuck on?
It's just stuck on your first slide.
Oh, I apologize.
That's okay.
I'm not sure why it's doing that. Any improvement or no?
Nope, I can see your mouse moving.
But it's still on the same slide. All right.
Can you try exiting your PowerPoint and then going back in? I'm sorry, everybody.
All right, I will do that.
Or stop sharing and then start it again. Maybe that'll help.
All right. Are you seeing a change now?
Nope.
Okay. Let's stop share and start again.
There we go.
Are you there?
Yep. Now, there we go.
Is it advancing?
Yep.
All right. Very good. Well,
About that, everybody.
All right, just to scroll briefly through then, you know, we've talked about what it did and didn't fix and the updates. It's going to replace and, take the place of meaningful use, PQRS, value-based payments, and these are actually going to be rolled into and replaced by the MIPS program. So, Victoria, everybody should be able to see screen or slide 6. Are you seeing slide 6?
Yep, we are.
Great. All right.
Thanks, Brian.
Oh, no problem. So the under the MIPS program, CMS is required to develop a methodology for assessing provider performance. So, you know, this is the step towards value and quality. So, in essence, CMS first has to develop a methodology for assessing provider performance. Then it's required to use that methodology to calculate a composite performance score for each provider. So each physician is going to have, under this program, beginning January 1 of 2019, every provider, every physician is going to receive a composite score between 0 and 100. Now, it's not a ranking per se. It is a score based on the quality process that it develops. So specifically, well, I'm jumping ahead here. So use the methodology to calculate a composite score, and then the composite score will be used to calculate the payment for the provider. So the adjustment the provider will receive each year will be a direct consequence of that provider's composite performance score. And as I note, this is going to begin on January 1, 2019. So MIPS is going to apply to physicians, of course, but it's going to apply to mid-level providers and CRNAs. Basically, there's even language in the legislation that allows CMS to expand that beyond just mid-level providers, CRNAs, and physicians. There isn't a specific requirement. It's going to be left to the secretary to determine that. But any professional that receives payment directly, physical therapist that has the ability to bill and receive payment, they may become subject to the MIPS program as well, and I think probably at some point in the future will. Obviously, or understandably, the MIPS is not going to apply to new providers in their first year of practice. If you have a doctor coming out of residency, their first year of practice, they're not going to be subject to the MIPS simply because there's no history, there's no way to score them. So your first year, you're going to get a zero adjustment, and then after the first year, the provider will receive their adjustment based on their MIPS composite score. All right, so that composite score is based on 4 performance categories: quality, resource use, clinical practice improvement activities, and meaningful use of certified EHR technology. So EHR and meaningful use are not going away. They're just being rolled in as a part of the adjustment, the annual adjustment. Now, the quality measures are going to be published each year. So, you know, CMS has not yet developed these. The legislation, I mean, this presentation is based on the legislation, the macro law that was signed back in April. CMS is busily working on the regulations that'll implement this. And so the legislation itself did not establish any quality measures or quality metrics. They're going to leave that to CMS, and CMS will develop those. One of the things I would say is that CMS has said repeatedly over the years that they want to try and make those quality metrics as uniform as possible. So we do have some quality metrics out there that are currently in existence. Those organizations, accountable care organizations participating in the Medicare Shared Savings Program, have 33 quality metrics in 4 domains. Value-based purchasing for PPS hospitals have, I think, another 64 quality measures. And so I think if you wanted to get kind of an advanced look at what the quality measures are going to be, I think if you take a peek at some of those other quality measures that CMS is already using, I think you'll get a general direction of where they're going. They have to be published each year, so pretty much like we see with other reimbursement issues, OP or outpatient prospective payment rates and other updates, we typically see those in July, August of each year. I think we'll then see, beginning in 2019, the quality measures. We'll get those published each year so that for the next fiscal year, you'll know what the quality measures are. Now, one thing that I thought was really interesting in the legislation was a specific statement that the quality measures may include population-based measures. For all of you who haven't yet in your mind, when you see that, drawn a dotted line to your needs assessment, you need to do so. I mean, under the IRS regulations, under the Affordable Care Act, every hospital has to do a community health needs assessment. That community health needs assessment needs to be done every 3 years, depending on when you did them. The first one needed to be completed, I think, by 2013. And so everybody's coming up on the end of their first cycle and going to need to do a new community health needs assessment. Well, a part of that community health needs assessment, of course, was what are the community health needs? But then there was, once those needs were identified, there were supposed to be strategies for addressing those needs. And I think that CMS is going to be looking at how successful communities were in addressing those community health needs assessments. And quite frankly, I think that we will start to see in these quality measures, we will start to see what CMS is looking at in our community health needs assessment. If there's a fair number of communities that have specific needs that are similar across the country, I think that CMS will be looking for ways to make sure that the hospitals and providers in those communities are implementing the strategies necessary to address those community health needs. So I think you need, in your mind, especially as you're moving forward into that new cycle of doing your community health needs assessments, you need to be keeping this in mind, because I think there will be a connection down the road. Should be up to slide 10. The clinical practice improvement activities component, they give us some specific detail there. This is what they're going to be looking for to reach a higher score under this portion of the measure. Expanded access, same-day appointments, after-hour access to clinician advice. I think a 24-hour nurse hotline is something they're going to be looking for there. Monitoring patient health conditions. Now, I haven't seen a lot of this out of CMS since we saw their regulations, initial ACO MSSP regulations back in 2011. But when you saw in those ACO regulations back then, you saw actually some language from CMS that they were looking for some sort of electronic monitoring of chronic health conditions. So is there some way for diabetics to stick their finger in, test their blood, and have that result automatically sent to their primary care physician? We haven't seen a lot of that yet. At least I haven't seen a lot of that yet. And I haven't seen a lot of talk from CMS about the details on that. But I think it's interesting that it shows up here. Monitoring of patient health conditions is going to be one of the required components for attaining a score under clinical practice improvement activities. So whether the primary care physician has some mechanism for actually getting that electronically or some other mechanism, I think it's clear. That CMS is going to be looking for that in the future. And then obviously care coordination. Victoria, I'm gonna ask you a question. I just had it pop up that my screen sharing is paused. I'm on slide 10 of advancing to 11. Do you have 11?
No, I don't.
All right. I'm not sure. Here we go.
Now I have.
All right, good. All right, so, and this is just continuing under what's going to be required for clinical practice improvement activities, beneficiary engagement, so care plans, beneficiary self-management and assessment and training. You know, it's a little unclear because it's still in the legislative and we don't have the rules from CMS actually talking about how they want to implement this. But, you know, it may be that we find that CMS is going to look for the physician to be carrying out some of this training for beneficiary self-management and assessment. So whether it's going to happen at the physician office level or whether it'll happen at the community hospital level remains to be seen, but it's on the list. And then patient safety, participation in an alternative payment model. Now, CMS went so far in motivating or pushing towards alternative payment models, and I think it's a move and an incentive to have the industry and the physicians move that direction, but I think it's also some guidance from CMS on what they're looking for, how they think this should work. So you see under the legislation that providers practicing in a certified patient-centered medical home will automatically receive the highest possible score for the clinical practice improvement category. So I think that tells me a couple of things. One, if you haven't started moving your practices towards being certified PCMH, you need to start moving that direction so that at least by 2019, you're there. And I think it also gives us guidance. This is what CMS is viewing as a model for communicating and also as a model of how that clinical improvement activity should work. If you are not PCMH by 2019, you get 50% of the highest possible score if you participate in another type of alternative payment model. So clear push, clear direction from CMS is to move this direction. Providers get credit for improvement. There will be in each of these quality measures, whatever they end up turning out to be, you will get points for your specific attainment level and your improvement from year to year. You see that same model under the PPS value-based purchasing program, where if there's one of those 64 quality metrics is how well the physician communicates with the patient. And if the threshold is at, let's just say, the 50th percentile and up through the 90th percentile, so just on performance to receive any sort of points, you have to hit at least 50th percentile or 50%. That's one way of getting points. There's also an improvement. So if at the base year, when they look at how well your patients rate, how well the physician communicates, if you had a physician that's not a great communicator and he only scored in the 10th percentile, and the next year he moved up to the 30th percentile, he's still below the performance base, but he's moved up and improved, so there will be some points. So a physician who improves, even if they don't approve to the very bottom level, will still get some points. All right, weighting of categories, because it always makes a difference. You know, if you need to work with your physicians to improve, where do we start? What's the basis? Where do we want to? Resource use starts at 10 and then over 2 years ramps up to 30th percentile. Clinical improvement activities 15, and then you see that meaningful use still is getting a fair amount of weight under this reimbursement model. All right, so each year they have to publish the quality performance metrics that go into these 4 categories, which in turn go into the calculation of the score. So there's going to be 2 things coming out each year. It's going to be the quality measures, and then you're going to have the performance threshold. Now, the performance threshold will not vary a great deal because the performance threshold, just skipping up. Well, all right. Back to slide 14. Published each year. The threshold is not going to vary a great deal because the threshold per the statute is the mean or the median of a previous performance year. Now, so the mean, median, obviously there is a difference for those statisticians in the group. It's not exactly the same, but roughly it's the midline, the 50th percentile. It's roughly there. And it's going to be the mean or median. CMS has the flexibility to choose either the mean or the median for a prior performance year. It's not necessarily the year before. It may be 2 years before or 3 years before. That's going to be up to CMS. We just know for sure it's going to be the mean or median of a prior year. Now, the impact of that is that, and we should be on slide 15, and let me know if we're not, Victoria. But, pardon me?
We're good.
All right, thank you. So the impact of that is providers with a composite score at or above the performance threshold will receive a 0 or positive payment adjustment, and providers below who have a composite score below the performance threshold will receive a negative adjustment. So just for the sake of ease in discussion, let's assume for the given year we're talking about, the performance threshold is the 50th percentile. So, or actually it's not even a 50th percentile, it will be a composite score of 50. So the performance threshold for this year is a composite score of 50. So if a provider has a composite score of 50, they will receive a 0 adjustment. No adjustment, no up or down whatsoever. If they have a composite score of 75, they will receive a positive payment adjustment because the performance threshold is 50, they're at 75, they're above it, they get a positive adjustment. If they're at the 90th, again, they get a positive adjustment, and providers with higher scores receive a higher payment adjustment. All right, so if you're at or above the performance threshold, you're going to get something positive. Well, you won't go negative. And that leads us, unfortunately, to those providers with a composite performance score below the performance threshold. So again, if our performance threshold is a composite score of 50, and you have a provider that has a composite performance score of 49, they will have a negative adjustment. And again, providers with lower scores receive a greater negative adjustment. So the further you are below the performance threshold, the more money you will lose in the subsequent year, because this is the adjustment for the compensation for the following fiscal year. Now, the applicable negative adjustment is for the first year, 2019, 4%, and then, because we should be on slide 16, you'll see that it goes 4, 5, 7, and then 2002 and subsequent years, the negative adjustment is 9%. So for those physicians who score below that performance threshold, which again, keep in mind, we don't know exactly what that performance threshold will be on a score, but we know that it will be the mean or median of a prior year. So, you know, this has kind of a couple interesting quirks from that. I mean, realistically, you have a situation in where about half each year, half the physicians, well, it's obviously more than just physicians, half of the providers, the MIPS providers, so that's also mid-levels and physicians, will get a bonus and half will lose. Half will get a negative adjustment. I shouldn't say a bonus, it's a positive adjustment, and the other half will get a negative adjustment. And you see here as the last bullet point, the statute specifically says CMS must ensure budget neutrality. So for those physicians who are going to see a positive adjustment starting in 2019 and moving forward, there is going to be a corresponding negative adjustment for a group of physicians in that same time frame. I'm amazed that the AMA let this go forward, but it was a fix. And, you know, I spoke to a number of people. We have a DC office, and so I'm out there and have that opportunity. And I spoke to a number of people, and the answer was, well, this fixes the SGR so that we don't have that constant can to kick down the road, and this doesn't take effect till 2019. If we need to fix it between now and then, we will. I think we just got a new can to kick down the road, quite frankly, because you know, the kind of the quirky thing about this is if you have a situation where the performance threshold is a composite score of 50, and you're at 60, and next year a bunch of physicians who had composite scores, let's just say, 5, 10, 15, decide to retire, all of a sudden the composite score that will be the mean will go up. So in theory, you could have a physician who was above the performance threshold in 1 year, stay at the exact same composite score, or in theory, maybe even go up. But if the performance threshold moves up, they will now get a negative adjustment. It'll be very, very interesting to me. And again, maybe I'm just too much of a geek or a nerd that I think that's interesting, but it's going to be very interesting to me, the CMS regulations that come out to address this, because they're going to get deeper into the weeds, into the detail of how this is going to work. And realistically, it should be interesting, I guess, is maybe not the best word for it, but it's going to be a mystery at this point. I'm curious how they're going to address it. I'm thinking that they are going to play it straight up, and they're going to wait and see what kind of pushback they get. And I think some of this may be, again, to help people be incentivized to move into alternative payment models, because there is additional compensation. You'll see here the third bullet point on screen 17. Providers that participate in a qualifying APM receive an additional 5% bonus. Those are paid actually as lump sum payments and are true bonuses. But that's the sort of motivation for moving people towards that model. I still have concerns about the fact that the performance threshold is always going to be the mean or median in a prior year, and that it has to be budget neutral, because it seems to me that that means each year 50% of the providers are going to lose money, up to 9% once we get into the fourth year of the program. Jumping up to the top of slide 17, another thing that I think is going to be kind of, it's a concern to me, problematic from a PR point of view, or potentially problematic, is CMS is going to include the physician, on the physician compare websites, each provider's composite score. So, I mean, right now, you can go out on the CMS physician and hospital compare websites and, be able to do some comparison. I don't know that many beneficiaries go out there and use that. I'm not sure it's really impacting beneficiary decision, patient decision on what physician they go to. But now they're going to have a composite score, and they're going to be able to flip through and go, oh, my physician only scored a 53, and this one down the road is an 89. I'm concerned about the potential impact of that. And so the reimbursement is one issue, and clearly that's a big issue, but this potential here has the potential to impact market share and the number of patients you're seeing in the first place. So I think that that's going to be as big a concern as the reimbursement, or potentially as big a concern as the reimbursement side. Now, CMS, I should say the legislature, because we're still talking about it at the statutory level, not the CMS regulation level, but the statute specifically has a provision for education. The statute says that each state's QIOs and others, and if I'm understanding correctly, I think the Michigan Center for Rural Health is working with MPRO in Michigan to provide this education. So the statute specifically provides funding for education for smaller practices. So specifically, practices of 15 or fewer physicians, with priority given to practices in rural areas, HIPSAs and MUAs. So there is, CMS has, or at least the legislation says, that there should be appropriated each year $20 million, starting in fiscal year 2016, and then running for, I think it's 4 or 5 years. There's this $20 million appropriated for this education. So, you know, I would encourage each of you to be looking for when MPRO and the Michigan Center for Rural Health is going to start this educational program, because I think those who become early adopters, those who get on board and get their practices PCMH certified and start taking advantage of this education, so that your performance under this new MIPS program is at the higher end of the scale, will cause or should cause you to be winners and receive positive adjustments early on in that program. And I think it's the folks that wait till later on and when the program actually starts in 2019 that are going to be a disadvantage. So I think you should be looking for information from MPRO and the Michigan Center for Rural Health for that. Moving on to slide 18. Now, this is, to me, a very interesting portion of the statute. All of this dealing with MIPS is very important because it drives reimbursement, it drives market share, it's all very important. But this is a look into the future. Under the Medicare Shared Savings Program, and in particular, well, the Medicare Shared Savings Program, in order to share shared savings with physicians and with hospitals and anybody participating in an ACO, CMS needs to know who that patient belongs to. I mean, if a patient, those beneficiaries receiving care, if the cost of providing care goes down, then CMS, under the Shared Savings Program, shares a portion of that savings with those providers. So somehow CMS has to come up with a mechanism for attributing those specific patients to specific providers. CMS now wants to move that, excuse me, now wants to move that methodology out of just the shared savings program and also into the general milieu of physician reimbursement. Realistically, if CMS is going to develop models for paying for value and population health, they have to know who those patients go to, who they connect to, which provider should get paid for that improvement in that patient's health. And so the current model, the current definition of the physician-patient relationship won't work. So CMS is actually, this legislation is directing CMS to develop care episode groups and codes and patient condition groups and codes. And so basically, they're trying to lump together care episodes into groups, and so they can assign them codes. The same thing with the conditions, because we all know that, you know, a patient who has 3 or 4 chronic health conditions goes in for surgery, they have complication rates different than those that have no chronic conditions. And so what CMS is trying to do is put together specific codes that they will later use or be able to use for payment codes, payment adjustments when it comes to patient condition groups and codes. And they're going to use those codes and groups to develop patient relationship categories and codes. And so specifically, the idea is CMS is looking for a way to attribute patients so they can make value payments and population health payments to the correct provider in the future. It's going to be very important to pay attention to this in the future, because it's not going to be the old physician-patient relationship. I mean, realistically, it's changed. I mean, historically, if I go see a physician, I'm that physician's patient. certainly I'm that physician's patient for as long as I receive care or receive treatment from that patient, or that physician, sorry, as long as I receive treatment from that physician. Well, that's good on a volume-based model. I mean, the more times I go see that physician, the more times that physician gets paid. But if CMS really wants to pay a physician for me not seeing them because my health has improved so I don't need to see them, or my chronic health issues are being addressed in a different way or through a different process, they need to connect me with a physician they can pay for that. And so this is the basis. And again, this is being built on CMS's experience through the Medicare Shared Savings Program and the attribution model there that attributes beneficiaries to providers that receive shared savings. So I think you need, I mean, the takeaway from this slide is, I think, a couple-fold. One, you got to understand that CMS is looking to redefine, at least for the purposes of payment, they're looking to redefine the physician-patient relationship, what it means to be a patient, how I become a patient of a particular physician. That's getting redefined, and CMS is looking at their experience with the ACOs and the Medicare Shared Savings Program and these development of these new codes to base that on. And the second thing I think that you should take away from it is this should be on your radar. What comes out in the regulations with regards to this should be on your radar because it's going to drive reimbursement in the future. It may be 3 years, it may be 5 years, but this is the future of reimbursement. All right, that's a lot to cover. I think we have about 5 or 6 minutes for questions. Actually, if there's questions go longer than that, I'm happy to stay on the line. So, Victoria, I'll turn it back to you.
Okay. I'll now open up the lines for questions, and then you can also feel free to use the chat feature, and you can type your questions either into me or Brian, and I can either read the question or Brian can answer it if you type it into him. I'm going to go ahead and unmute everybody, so just be aware that if you are having a sidebar conversation that we will be able to hear you. Okay, so all lines are unmuted, and so you can either raise your hand and that will notify me, or you can feel free to just say your question. Okay. Do we have any questions for Brian? Okay. Not looking like we have any questions, Brian.
Oh, that's fine. Well, thank you, everyone. I appreciate the opportunity to meet with you by webinar today. And if questions do come up, please don't hesitate to either reach out to Victoria or myself. My contact information is there on the last slide. So thanks, everyone, and thanks, Victoria.
Yep. And if you do have any questions, do feel free to reach out to me, and I will pass them along to Brian, or you can contact him directly. He will answer you. If we don't have any questions, I guess we'll go ahead and sign off. And I did record the webinar, so we will be posting it on our website as well or you can reach out to me if you would like a copy of the recording. I will send it out. Okay? I guess we'll end it there if we don't have any questions. Thank you.